Hello and welcome everyone. In this video, we are going to discuss about UTI or urinary tract infection. In this video, we will discuss about what is UTI, causes of UTI, bacteria involved to occur UTI, pathogenesis, what are the symptoms, risk factors, and the treatment of UTI. Urinary tract consists of urethra, bladder, ureters, and the kidneys. If the infection occurs in the kidney, that known as pyelonephritis. Similarly, if the infection occurs in the ureter, it's known as urethritis. If the infection occurs in the bladder, that is cystitis, prostatitis, and urethritis in the prostate or urethra, respectively. Now we are going to discuss the reason to having UTI infection. UTI can be seen in both sexes like male and female, and even all the ages group from baby to elderly patient. A good, healthy urinary tract can resist to the bacteria. This can be achieved by maintaining good hygiene and sufficient water intake. Here, UTI can be seen more in female than in male. There is a few reasons like shorter urethral length than in male, shortest distance between the rectum and the vagina, which make easy passes the bacteria. In hormone changes, especially in decline of estrogen hormone, like in menstrual cycle, pregnancy, and in menopause and using a birth control technique like spermicides, diaphragms can be cause of having more UTI prone. A few disposing factor can also reason to having UTI like diabetes mellitus, congenital anomalies, that is, inheritable medical condition that occurs at or before birth, and in obstruction lesions occur when the flow of urine is blocked, cause urine to back up and potentially damage in the kidney. Here we can see that how bacteria are passing from rectum to the urethra. Easy passes of bacteria can be seen here because of shortest distance of rectum to the urethra, as we have discussed. In the second picture is showing burning urination or difficult in urination. A few risk factors are shown here, especially in women, like bacterial infection, poor hygiene in the genital areas, in pregnancy when estrogen levels are low, diabetes mellitus are the predisposing causes, hormonal changes when especially estrogen levels are low in pregnancy, menstrual cycle, and menopause, weak immunities as the body's defense mechanism are compromised, increasing susceptible to the bacterial infection, and the kidney stones, catheterization in the hospital are the main causes of UTI or the risk factor. Last one is showing the bladder infection known as cystitis. We are going to discuss briefly about pathogenesis and bacteriology involved in UTI. Maximum number of UTI causing organisms are originate from the rectum. In the picture, here it's shown all the bacteria that cause UTI are originate from the rectum. In female individual having established infecting bacteria in the vaginal orifice or canal cause bladder infection from bladder to the kidney in the ascending order. But normal or healthy urinary tract can resist the infection by following mechanisms are infecting bacteria washed out with the urination. Second, inhibit growth due to low pH 5.5, high urea content, and high osmolarity of the urine. Direct destroyed by the antibacterial action of the bladder mucosa. Bacteria involved are like Klebsiella, Enterococcus, E. coli, Proteus, Pseudomonas, and Staphylococcus. Among all the bacteria, 95% of UTI infection are due to E. coli, that is gram-negative bacteria. Here in the picture, we can see E. coli, Streptococcus, and Staphylococcus that mostly cause UTI infection. UTI chronic infection. In case of chronic condition, mixed infection are seen commonly, like in diabetes, obstructive uropathies, and in bladder catheter. Mixed infection are difficult to treat. Investigation of the UTI infection. Number one, identify by quantitative culture, that is colony count of the bacteria in per ml. If the bacteria is 10 to the power 5 per ml, consider a significant infection. Second, urine can be taken for investigation from midstream urination. Third, a little painful and more avoided is suprapubic bladder puncture. Fourth, if men having UTI mostly investigate the focus of infection in the prostate. Here in the picture is shown here, urethral opening is normal in normal prostate. In enlarged state of the prostate, urethral opening is narrow. According to the investigation, UTI can be divided into two types. Number one, asymptomatic bacteria and symptomatic abacteria. Let's discuss about asymptomatic bacteria. Asymptomatic bacteria can be determined by presence of bacteria without any noticeable signs and symptoms. It is commonly occurs in the older adults and those with urine catheters and in females. ASB is only treated in pregnancy and urological procedure. Few women with acute cystitis may have more than 10 to the power 4 and less than 10 to the power 5 bacteria per ml of urine. Healthy individuals with normal urine tract or in corticosteroid therapy excrete in the urine bacteria in excess of 10 to the 5 per ml, but it is asymptomatic bacteria. Let's discuss about symptomatic bacteria. Here, presence of bacteria in the urine along with the symptoms like frequent of urination, dysuria, pyuria, and urethritis may have less than 10 to the 5 per ml of bacteria in the urine, but presence of signs and symptoms with the bacteria. A urine culture is determine the presence of bacteria. Most of the condition either due to the chlamydia, non-gonococcal urethritis, and gonococci. Let's discuss about common symptoms for urethritis. In male, penile discharge, burning or painful urination, discomfort or itching. In female, vaginal discharge, burning or painful urination, bleeding between the periods. Now let's discuss about gonococcal urethritis and non-gonococcal urethritis. Gonococcal urethritis incubation period is 2 to 5 days, whereas in non-gonococcal urethritis incubation period is 2 to 3 weeks. Onset of symptom is abrupt, suddenly, in gonococcal urethritis, whereas in non-gonococcal urethritis, onset of symptoms are gradually here. Non-gonococcal urethritis associated symptoms are less severe, whereas in gonococcal associated symptoms are usually severe. In gonococcal urethritis, patient present with intense burning sensation while passing urine, absent in non-gonococcal urethritis. Discharge is profuse and yellowish green in gonococcal urethritis, whereas non-gonococcal urethritis discharge is usually mucoid. Gonococcal urethritis symptoms are fever and malaise may be seen. In non-gonococcal urethritis, these are absent. Gonococcal urethritis can be caused by Neisseria gonorrhoeae. Treatment is ceftriaxone IV. Non-gonococcal urethritis are due to various organisms like bacteria, virus, fungi, and parasites. Treatment for non-gonococcal urethritis are doxycycline, metronidazole, clotrimazole, and fluconazole. Symptoms of UTI. Types of UTIs are kidney, bladder, and urethra. Now let's discuss one by one symptoms and signs. Kidney infection is known as pyelonephritis. Symptoms are upper back and side pain, high fever, shaking and chills, nausea and vomiting. In bladder infection is known as cystitis. Symptoms are pressure on pelvic area, low abdomen discomfort, frequent and painful urination, blood in urine. Urethra infection is known as urethritis, burning with urination or discharge. How a UTI affects the body. Fever, chills, back or side pain, frequent urination, burning while urination, passing less urine, cloudy with discolored urine, pelvic pain, nausea and vomiting. These are the signs and symptoms can be seen in UTIs. Drug therapy of UTI. Goals for the treatment of UTI are Symptomatic relief by altering the pH of urine and or giving phenazopyridine, this 200 mg tablet once daily. Therapy of the infecting organism. Third, preventing and treatment of reoccurrence of UTI. Identification and treatment of predisposing factor. General principle for drug therapy in UTI. In acute cases, an appropriate drug can be started as soon as the urine has been collected for screening, means in lab. In chronic cases, missed infection are most likely to seen and concomitant renal failure may modify the drug therapy. In such cases, wait for the investigation result. If the infection in the tissue level, then choice of drug must be adequate concentration in the tissue as well as in the urine. Further, the effect must be in the vaginal flora for last long for eradication of bacteriuria. In this case, choice of drug would be trimethoprim and fluoroquinolones. E. coli optimum growth in the pH of 6 to 7 and inhibit below 6 and above 7. This can be achieved by administration 2 grams of sodium bicarbonate, sodium and potassium citrate, which enhance antibacterial activity of penicillin, erythromycin, and aminoglycosides. All pregnant women should be screened for bacteriuria in the first trimester. If found, then must go for treatment, which reduce risk of pyelonephritis, that is kidney infection, premature delivery, and low birth weight of the baby. 7 to 14 days treatment are recommended, and further investigation for reoccurrence. Classification of drug: bacteriostatic agent, that is sulfonamides, tetracycline, nitrofurantoin, bactericidal agent, which kills the bacteria, clotrimazole, ampicillin, extended spectrum penicillin, aminoglycosides, fluoroquinolones, cephalosporin. Now let's discuss about drug used in UTI. First one, sulfonamide. It is effective in E. coli. It is effective both urine and tissue level, but the major problem of develop resistance. Hence, use 4-trimoxazole for twice a day for 7 to 10 days. 4-trimoxazole is a combination of two drugs, trimethoprim and sulfamethoxazole. Hence, trimethoprim is teratogenic, so avoid during pregnancy. Ampicillin, E. coli, Aerobacter, and Proteus. It effects good result in these. It produces good in tissue level and excreted unchanged in urine in high concentration. Dose given here is 0.5 gram for 7 to 10 days. But ampicillin developed resistance of hospital-acquired UTI, first drug of choice for UTI in pregnancy. Aminoglycosides antibiotic, E. coli, Proteus, and Pseudomonas. Aminoglycoside antibiotics are gentamicin and amikacin are mostly used for UTI. These are given IV and can cause ototoxicity and renal toxicity, hence given in single doses and can be treated for complicated UTI also. Fluoroquinolones. It is deal for subnormal renal function. This is useful in nosocomial, pyelonephritis, and complicated UTI. More effective and pH level 7. Next one, nitrofurantoin. This is more effective in urine concentration than the tissue level. This is less useful but effective in acute UTI. Dose would be 50 to 100 mg per day for a week. This drug is antagonist with naldexic acid. Cephalosporin. This is effective against E. coli. Proteus is resistant with other antibiotics. This is more effective in calbacillar infection. Third generation cephalosporin are good effective in multi-resistant enterobacteria and pseudomonas resistant with other antibiotics. Now let's discuss choice of antibacterial therapy of UTI is determined by the site of the infection in the urinary tract, whether a predisposing cause such as diabetic mellitus or an abnormality of the urinary tract is absent or present, and whether the infection is caused by drug sensitive or drug resistant organism. Different type of urinary infections are bladder infection, known as cystitis, urethritis, and infection in the urethra, kidney infection, pyelonephritis, ureter infection is known as urethritis, and especially urine infection in the female. UTI risk factor we have already discussed pregnancy, menopause, chronic health conditions, sexual activity, birth control technique, personal hygiene. Now let's discuss about treatment of upper UTI. In the picture, we can see acute pyelonephritis and chronic pyelonephritis. Acute pyelonephritis, this is commonly happen with a predisposing factor and patient may be septic and severely ill. For acute pyelonephritis, few drugs are used are ciprofloxacin 500 mg twice a day for 7 to 14 days. Cephalosporin with or without gentamicin, cotrimoxazole orally 2 tablets twice a day. Ampicillin 1 to 2 gram orally or IVly. In pregnancy, IV cephalosporin and or an extended spectrum penicillin are indicated. Severely ill, hospitalized, and complicated patients are given empirical treatment. Third generation cephalosporin, fluoroquinolones, carbapenem, piperacillin plus tozobactam, sometimes with gentamicin for 10 to 21 days, then routine urine culture. Ciprofloxacin or an extended spectrum penicillin has to be used in infection due to highly resistant organism. If fever and flank pain persist after 3 days of treatment, then go for urine culture and ultrasonography carried out to rule out perinephric or internal abscess. Treatment of upper UTI infection, chronic pyelonephritis. This is a serious condition which leads to chronic renal failure. If the UTI is recurrent, then it is caused to chronic pyelonephritis. Choice of drugs should be given only after thorough investigation of the organism and they are sensitive to the chosen drug. Symptoms are pain inside, back, and abdominal area, needing to urinate at night, reoccurrence of UTI, CKD, chronic kidney disease, hair, ankle swelling, tiredness, and itching. Renal impairment, tetracycline except doxycycline must be avoided in chronic renal failure. The dose of aminoglycosides and cephalosporin must be scaled down. Nitrofurantoin and naldexic acid do not achieve adequate concentration in patients with renal failure. Their systemic toxicity is increased in such patients. Treatment of lower UTI. Lower UTI tract consists of bladder and urethra. If the bladder gets infected, it's known as cystitis and urethritis and infection in the urethra. Acute uncomplicated cystitis and urethritis. Here, both bladder and urethra gets infected. The first attack of young woman patient with 3 days therapy can reduce rectal carriage of gram-negative bacteria. The choice of drug here is cotrimoxazole for non-pregnant patient. If the patient is pregnant with cystitis, then we will advise amoxicillin, cephalexin, cefodoxime, ceftriaxone, and nitrofurantoin are treatment options. Single dose therapy with fosfomycin trimethoprim 3 gram has been advisable for pregnant women, though it's very costly. Follow-up urine culture is needed till delivery. Recurrent infection. The use of diaphragm, spermicides, vaginal tampons has been associated with recurrence in some patients. Those patients should receive treatment for at least 4 to 6 weeks with cotrimoxazole or a fluoroquinolones or with amoxicillin, clavulanic acid combination, cefixime or cefodoxime. In patients with suspected prostatic focus of infection, drugs like trimethoprim, erythromycin, fluoroquinolones, doxycycline, and aminoglycosides are recommended. Postcoital cystitis. Some women seems to get lower UTI infection after every sexual intercourse, and some of them produce symptoms also. These patients get full course of antibacterial treatment. Followed this, apply 0.5% cetramide cream in the periurethral area before coitus and empty the Bladder immediately after the sexual act. After this, take a single dose of amoxicillin 250 mg or nitrofurantoin 100 mg or cotrimoxazole tablet after each coitus. Prevention of UTI. Simple changes in lifestyle can prevent you from UTI infection. Urinate and wash immediately after intercourse. Drink enough water to keep you hydrated. For female, wipe genitals region from front to back, that is vagina to rectum, because maximum UTI caused by rectum's bacteria. If you are a diabetic ill patient, then manage your sugar level. Wash the rectum after each defecation. Maintain hygiene by washing hands after using washroom. Wear clean underwears. Use clean and washed towels to clean or dry your genitals. Note: even though you are getting infection, consult your healthcare professional as soon as possible.